Welcome back to the Cambridge Neuroscience Interdisciplinary Seminar Series. This series features current work from neuroscientists across the schools and departments of the University of Cambridge, reflecting the pioneering work and diverse interests of our members here. Each seminar focuses on one of the new interdisciplinary themes of Cambridge Neuroscience, and for more info on the talks covered in this seminar series and all things neuro-related here at Cambridge, please follow us on Twitter at CamNeuro and follow the links below. Okay, so good afternoon, everybody, and welcome to the last in this term of the Cambridge Neuroscience Interdisciplinary Seminar Series. It's been a great term, and thank you all, especially those of you who've joined us for many of the different seminars. Today, we're delighted to welcome Dr. David Bulmer. David is an associate professor here at the Department of Pharmacology at Cambridge. He has previously, he did his training at UCL. He was in GSK, and then he was working at Queen Mary down in London before he joined us, I think back in 2017, if I'm not mistaken.
Yeah, that's right.
Yeah, he's a bi-fellow of Wolfson College. And as you will know, because you're here, his research interests are all about pain. So whether it be inflammatory bowel disorder or irritable bowel syndrome, it's all about the visceral pain with David. So we're delighted to have you, David. Thank you so much. And over to you.
Brilliant. Lovely. Are you getting the little videos in the corner of the screen, or I take it that's just No, it's not obscuring the slides. Yeah, no, I think it's just the way mine's set up. Okay, lovely. So I want to talk to you today about how we can treat visceral pain, and this is, I suppose, a question mark there really, but this is a question I've been working on for the last 10 to 20 years now. So just by way of there we go. A brief introduction. We're going to be talking predominantly about abdominal pain. We're talking about abdominal pain and gastrointestinal diseases. If we think about GI diseases, we're typically looking at two main types. We're looking at chronic or organic diseases. So this is inflammatory bowel disease, and we can see a picture of a rather nasty looking colon from a patient with Crohn's disease on the right-hand side. And unsurprisingly, these patients experience quite a lot of pain, moderate to severe intensity. It isn't unusual for IBD patients to be hospitalized for management of pain. And as one might predict from that picture, it seems very likely that the main cause of pain is inflammation and the release of inflammatory mediators. For a lot of patients, the pain persists during remission. So about 50% of IBD patients will go on to have chronic long-term pain. And we think in that situation, a hypersensitivity of the visceral pain system has occurred. And this is promoting long-term changes in pain processing. So we have a need to treat acute inflammatory pain, but also more chronic persistent pain in IBD patients during remission. And this is very similar to the second main type of GI pain that we look at, which is irritable bowel syndrome. So unlike inflammatory bowel disease, where we have that very obvious and marked pathology in the bowel, this is an example of a gut. This could be a patient with irritable bowel syndrome, and this is a very healthy looking bowel. So there's no obvious overt pathology in IBS patients that have led some people to question really if there is an underlying disease. And I'll show you some data in a minute which strongly suggests that there is an underlying problem. And certainly from the perspective of the pain sensing nerve, these two conditions actually probably look quite similar. So we have what's referred to as a functional disorder. There's no frank pathology, but there's been a change in how the bowel functions, and in particular, how we sense events in the bowel of IBS patients. And this is usually accompanied by either diarrhea or constipation. So we have an altered motility pattern that occurs at the onset of pain and resolves with the resolution of pain in those patients. And we think this visceral hypersensitivity that we spoke about in IBD patients in remission is also occurring in IBS. So maybe there's an overlapping pathology that we can get at to treat visceral pain in these two diseases. So what is visceral hypersensitivity? Well, most of us go back nearly 50 years now to the seminal work by Ritchie, who was head of surgery at the Royal London Hospital, and he inflated a balloon in the descending colon of healthy volunteers and patients with IBS. And if you look on the right-hand side, you can see the data from that study published in 73. And you'll notice at 100 milliliters of balloon inflation, about 50% of healthy volunteers experience pain, but nearly all IBS patients experience pain at that volume of inflation. And if we look at 60 mils of balloon inflation, we can see most people wouldn't be able to sense that, but over 50% of IBS patients are experiencing pain in response to that much lower level of balloon inflation. So sensitivity to colonic stimuli is greatly enhanced in IBS patients, and we refer to this as visceral hypersensitivity. So if we're going to treat pain in these conditions, we nearly need to get a handle on what's causing this visceral hypersensitivity. And there's two popular ideas in terms of what's driving this. Shall I just click on that? So certainly one popular idea is that this is top down. And so the presence of stress, depression, or anxiety, which promotes a level of hypervigilance, is having an impact on the bowel, and this is driving pain in these patients. And most of us will be able to associate with the idea of butterflies in our tummies, and most of us will be familiar with the fact that our bowels do feel different during periods of stress and anxiety, but this isn't necessarily pain. The alternative hypothesis is that some kind of prior infection or allergy has set up a sensitization of the visceral nociceptors that innervate the bowel, and this is producing longer term changes in the set point of pain sensation from the bowel. So this is our friend visceral hypersensitivity, and it's likely for most patients a mixture of the two, both a peripheral change and a central change in how we perceive the bowel, typically in response to stress, anxiety, and depression are at play. And this results in a hypersensitivity. So all of a sudden, normal bowel movements become perceived and get perceived as pain. So my group's particularly interested in this portion here within the bowel itself, and we're particularly interested in how these pain sensing nerves or nociceptors become activated. And the reason why we focused down in the periphery is that provides an opportunity to treat these conditions with peripherally restricted drugs. So quite often, some of the medications that could switch off pain sensing nerves have quite marked or profound effects on CNS function, and we need to avoid that in order to treat patients, particularly those with a chronic lifelong disease, in a relatively side effect free manner. So we've largely focused our work on the peripheral nociceptor in order to identify peripheral drug targets that can be treated with restricted drugs. So we spoke about visceral nociceptors. What are they? Well, the bowel receives an innervation from two different anatomically distinct sensory nerve pathways. We turn our minds back to 1947 and a rather seminal study that I don't think you would get the approval to do now by Ray and Neil over in the US. And they were treating patients with chronic intractable pain from the bowel. These were cancer patients, and they performed bilateral sympathectomies at a range of different levels in order to eradicate the pain the patients were experiencing from the bowel. And while doing this, they inflated a series of balloons along the GI tract. So these black circles are meant to represent these small balloons that they inflated at different points along the gut of these patients. And the 0 represents an absence in the sensation of pain following a bilateral T7 to L3 sympathectomy. So as a consequence of these studies, we now know that most of the pain signal from the bowel is actually traveling with the splanchnic nerve. So if we think about the descending colon, which is the area we'll focus most of our research on, this is largely coming from the lumbar splanchnic nerves that are terminating at T10 and L2 levels in the spinal cord, as opposed to sensory nerves which travel with the pelvic nerve, which are only actually innervating the sort of final foot of bowel. So predominantly pain from the rectum would be conveyed through the pelvic nerve, but pain actually from most of the colon and the intestine and whatnot is traveling with the splanchnic nerves. And these are slightly different sensory nerves, and we'll touch on that in a minute. So the data that we looked at in the study for Ritchie, the balloon was placed 35 centimeters into the bowel. So this is all work on the lumbar splanchnic nerve. So we can study that nerve in mouse. We can euthanize the animal. We can take out the colon. We can isolate these lumbar splanchnic nerves. Just to give you a quick idea of what it looks like, this is a colon in a tissue bath. I'll just play a quick video. It's a little bit hissy. I apologize for that. It's quite old now. But effectively, this is a recording of nociceptor activity. And those clicks that you'll suddenly start to hear are the nociceptor firing action potentials in response to a test stimulus. So it's quite a simple preparation that we use for most of our work that's been around for many years now. So if we take a bit of mouse colon and we inflate it, we can record the response in action potentials generated within those sensory nerves. And you can see, if we look at the rate histogram, that most of the nerves begin to respond around about 14 millimeters of mercury. And that's really quite nice, because this maps very well to the pain threshold experienced or reported by patients following balloon distension of the colon in humans. So we think there's good face translation of the threshold for nociceptor activation in the human colon with the mouse colon. So how's that response mediated, and can we begin to target some of these processes to treat pain in humans? So we know quite a lot about this. This is work that kind of started in the early 2000s. Obviously, there was a Nobel Prize awarded recently for the discovery of TRPV1 and piezo2. In the bowel, a lot of the work on mechanotransduction is focused on TRPA1 and TRPV4, and there's a series of landmark papers from Stuart Brierley over in Adelaide demonstrating the importance of these TRP channels in gut mechano sensation. So these TRP channels detect noxious distension. This sets up the generator potentials. These are amplified by voltage-gated channels with a low activation voltage. So if we think about the sodium subtype, NAV 1.9 is particularly important in amplifying these generator potentials, and this increases membrane potential to a point that triggers action potential firing, and the signal travels up to the CNS, and we experience that as pain. So if we can interrupt the activity of these channels, we can stop the nociceptor from firing in response to a noxious stimulus, and potentially we can treat visceral pain. So on the left, I'm just illustrating that with some data from my group. The line here in the middle is the response to a normal distension of the bowel. And if we give a TRPA1 channel agonist, we can sensitize that response. And if we give a TRPA1 channel antagonist, we can block that response and reduce noxious firing in the bowel. Similar data, this time using a TRPV4 antagonist, and we can greatly inhibit the activation of pain-sensing nerves to distension in our mouse tissue preparations. So it's relatively easy to block mechanical activation of nociceptors. Typically, as I mentioned earlier, we want to treat pain during inflammation and following inflammation. So what's happening in that situation? Well, we've got immune cells, we've got mediators released from those immune cells, and mediators released from the damage those immune responses cause in the bowel. And the take-home message here is most of the receptors that these mediators stimulate aren't necessarily ion channels, although there are a few ligand-gated ion channels of importance. But many of these mediators will stimulate G protein coupled receptors or cytokine receptors, for example. And so in order to make those sensory nerves fire, these receptors are modulating the activity in these same ion channels that are important in the stimulation of those nociceptors. And some will even switch off potassium channels in order to help depolarize those afferent endings. So we can look at this as well. So for example, we've given bradykinin in the past to stimulate colonic nociceptors. We've looked at this response in mice lacking the amplifier channel NaV1.9, and you can see that we lose that response to bradykinin. We can give an opener of potassium channels that are typically inhibited by inflammatory mediators. So this is the KCNQ subtype, and we can give retigabine, a KCNQ channel opener, and we can abolish that same response to bradykinin. And actually, if we give retigabine during the bradykinin response, you can see that we can bring that to a rest quite nicely. So the summary really of this part of my talk, is that we embarked on an exercise to try and understand ways in which we could block nociceptor signaling, and certainly in the mouse. It's pretty easy to identify drug targets and to validate these drug targets for the treatment of visceral pain. And I've shown you examples for NaV1.9, KCNQ or KV7.2 to 5, TRPA1 and TRPV4. And that certainly was the state of play, some 10 to 15 years ago. And there's lots of decent drug targets floating around the pharmaceutical industry that may be effective. I mean, the real challenge was a sense of what would work in the clinic. And I think that's what sort of arrested a lot of drug discovery in this area. And this was the challenge that my group went on to sort of address when we first set up our lab down at Queen Mary. So how can we improve our confidence in these fairly well-established drug targets? And in a rather straightforward manner, we turn to human tissue, and we reasoned that if we could get samples from these patients with IBD or IBS, we'd be able to better understand the specific mediators or generate a patient-specific challenge for those sensory nerves. So something other than bradykinin. We also argued if we were able to remove the colon from a mouse and look at visceral nociceptor activity in mouse colon, then we could potentially do the same with surgically resected human colon that's no longer required for diagnostic purposes within the hospital. And most of this work was done at the Royal London Hospital in London. So we set about doing that. So the first study we did, we actually exploited surgically resected bowel taken from IBD patients. So certainly for UC patients, this can be a cure. So we get a lot of tissue, and we performed a very straightforward study. We incubated surgically resected bowel from IBD patients in physiological buffer for 25 minutes. We removed the bowel, we spun it down to get rid of the debris, and we took the supernatant from those samples and applied it into those same nerve preps that I showed you before. And this is the response. So we've got a control supernatant taken from healthy tissue, resected margins in cancer patients that has no effect on afferent firing at all. But if we apply supinatants from patients with Crohn's disease or ulcerative colitis, you can see we get this very robust increase in nociceptor firing. And if we repeated those studies in tissue from a NAV 1.9 knockout mouse, you can see we can pretty much completely abolish that effect. So we've taken our findings a step further and shown that NAV 1.9 is important in the activation of visceral nociceptors to stimuli coming from the patient themselves. We took this further, and in a series of studies, we actually opened up the gut this time, and this allowed us to identify the nerve endings. So this would be the ending of a single nerve fiber in the tissue. The reason why we did that is we can then isolate that nerve ending. We can characterize it using a series of probing and stretching and stroking stimuli. So the pain sensing nerves only respond to the probing of the tissue, not tissue stretch or tissue stroking. And we did some comparator studies where we showed that they had this high threshold to activation, consistent with their activity as a nociceptor, whereas the stretch sensitive afferents had very low thresholds to activation. And what was nice about this study is we could then isolate that receptive field and give a very small volume of test supinatant directly on the nerve ending. And this allowed us to use samples that had been taken by biopsy, so much smaller samples than the surgically resected pieces of colon. And this now gives us access to a much broader range of patients. Before, we were only working on supinatants from IBD patients that had a very severe form of the disease, and as a consequence, we're going for surgery. Now we can get samples from IBS patients and IBD patients, and we can get repeat samples from the same patient, which is very important moving forward. So we did a number of studies with this setup looking at biopsy responses. The first was really cool. So this was done by a postdoc of mine, Vincent. We got some samples from Guy Bockstein at the Catholic University in Leuven. Guy had gone to a village outside Antwerp, and there'd been a contamination of the local water supply. So these poor people had been infected with Giardia, norovirus, and Campylobacter, and developed a very nasty gastroenteritis, and subsequently, several years later, we're still complaining of visceral pain and IBS-like symptoms. So Guy was able to collect some biopsies from those patients and generate some supinatants. So we got some healthy volunteer samples to run alongside this. We incubated these biopsies for much longer, for 24 hours. And you get a little tickle if you do that using a biopsy from a healthy volunteer. And this is probably a prostaglandin release during incubation. But it's only a small response. We don't get any particular sensitization of the response to probing the nerve ending. But you can see that it's night and day when we compare that with the biopsy supinatant from the patients that had gastroenteritis and went on to display IBS symptoms. And we get a very marked increase in their firing. And if you look at the probed response, once we've removed the supinatant, then you can see that nerve ending is greatly sensitized, and it continues to fire long after we've removed the probe stimulus. So we're creating visceral hypersensitivity in the lab using samples taken from IBS patients in response to a contamination of the local water supply 3 years earlier. So we were quite happy with this. It was good evidence that we'd set up a preparation which was giving us a window into what was happening in IBS. So we took this further. We did a study with Robin Spiller at the University of Nottingham. This was pretty cool. Robin had biopsies from 42 IBD patients that were enrolled as part of a clinical trial that he had ongoing. And what was nice about these is we had really good clinical scores, both for sensory symptoms, motility symptoms, and we had the hospital anxiety and depression score. So we could compare our responses back to these clinical scores, which is incredibly useful. So this just shows you a similar thing. This is a supernatant taken from one of Robin's IBS patients. Again, you can see this really marked increase in firing. So, I mean, just to make the point, although the bowel looks normal in an IBS patient, if you're a nociceptor, it doesn't look normal at all. Through the lens of the nociceptor, it's quite abnormal. And it's perhaps no surprise that the patients are in pain when their bowels are able to stimulate pain-sensing nerves to this extent. We gave the same supernatant to the mice lacking this voltage-gated sodium channel NAV 1.9, and you can see it no longer causes the nerve to fire. So we validated the NAV 1.9 as a target using supernatants from both IBD and IBS patients in the end. But this was a really interesting thing. So if we took the firing caused by those supernatants and compared it with symptom scores related to diarrhea or anxiety, we saw no correlation whatsoever. Yeah, so it didn't matter the extent to which the patients had diarrhea, and this is the Bristol stool form scale, which is a very handy measure of diarrhea. So around about 4 is sort of reasonably fluffy stool. This is very, very loose stool indeed, and it didn't matter how anxious the patients were either. And at the far end, you can see there was some patients with quite high anxiety scores, and there's no correlation whatsoever between those symptoms and the ability of the supernatant from that patient to stimulate visceral nociceptors. However, if we correlated that response with pain severity, we get a very nice significant correlation. So we think what we're looking at is very specific for pain symptomology, which would suggest that we're looking at something mechanistically relevant. What was quite interesting on top of that is you can see that there's actually a pretty good correlation between a subgroup of patients and perhaps not such a good correlation between other patients, you know, that didn't show a great change in nerve activity at all. So this led us to ask, you know, whether there was a specific patient subtype that particularly had a marked change in the pro-nociceptive potential of their bowel. So we went back to Guy. This time we've got a photo of Guy in Leuven, and he'd done some further biopsy studies. This time he'd given a rectal Baristat as well as taking a biopsy. So he measured the pain threshold of each patient. And what we observed, again, a very binary observation, is in the patients that had very low pain threshold. So these are the hypersensitive patients. They have the biopsies that produce supernatants that stimulate nociceptors. And the patients that had pain thresholds fairly similar to the general population had very little response when we applied the supernatants. And you can see that difference between the left and right sides here, and the hypersensitive patient supernatant went on to stimulate the response to mechanical stimuli. So it looks very much that we've got that hypersensitivity within a subpopulation of patients, and these are the patients with the peripheral changes that are driving nociceptor activation and hopefully pain. So we asked a fairly obvious question, which is, well, can we get at what's driving this and not only validate some of our existing targets, but potentially find some new ones as well? Yeah. So we went to, so we turned to Nicholas Senac. This is a picture of Nicholas taken from the Interpol file on him held in France. And Nicholas had performed a lipidomic screen. So he'd looked at these arachidonic acid products in controls, patients with mixed IBS, constipation predominant IBS, and diarrhea predominant IBS. And the greens represent very low levels, and the reds represent very high levels of lipid concentrations. And you can see there's quite a marked difference in the lipid profile between IBS-D and IBS-C patients. And what I want to sort of draw your attention to is this box here, and this mediator here, 5,6-EAT. And Nicholas had earlier shown that 5,6-EAT is produced in response to the release of proteases from immune cells, which act on a specific receptor, PAR2, which in turn promotes the production of 5,6-EAT. And 5,6-EAT is actually an endogenous agonist at the TRPV4 channel that I showed you earlier in the slide deck. So it looks in IBS patients, we're getting actually the production of a natural ligand that stimulates the TRPV4 channel, which is the channel through which the gut senses mechanosensitivity. Yeah. So we thought this was pretty cool, and we went on and we repeated our supernatant study, this time using tissue from mice who lacked TRPV4, and indeed, consistent with Nicholas's data, we saw a significant reduction in the supernatant response. And we took this through into recordings from human colon. So this is a piece of human colon. We've opened it up into a small flat section. We've recorded sensory nerve activity coming out into the mesenteric fan. We've identified the receptive field of a human colonic nociceptor, which we've probed. We get no change in the probed response, very stable in the presence of vehicle. But if we give a TRPV4 antagonist, we can significantly reduce that mechanosensitivity in human afferents. So again, good data backing up a role for TRPV4 in visceral pain, both in human tissue and in response to a human disease supernatant. So we think we're getting better at building some translational success in what we're doing. So we were keen to really, go back and find some novelty. So if you noticed in the IBS-C lipidomics, you can see there's a collection of mediators only found in patients with constipation predominant IBS, and in particular the response to 5-oxo-EAT was highly elevated only in the IBS-C. So we thought, well, is this important, and can we use it to identify new treatments for pain in IBS-C patients? So just to summarize an awful lot of data, so one of the first things we did was we brought in some oxo-EAT, we applied it to sensory neurons. There's two flavors of sensory neurons if we just isolate them and look at them in culture. Some that bind the isolectin B4 and are referred to as non-peptidergic, and some that don't bind it and are referred to as peptidergic because they contain CGRP and substance P. Both are nociceptors, but there's slight differences in the receptor expression between these two populations. And we were, to our surprise, we found that the oxo-EAT only stimulated one population. Now, what's quite interesting about this population is it expresses a very distinct G protein coupled receptor known as MERG-D, which is almost exclusively found in this nociceptor population. And so we went and looked to see if the nociceptors innervated the bowel also expressed MERG-D, and indeed they did. And we found about a third of nociceptors innervating the bowel express MERG-D. This is some immunohistochemistry. So these are mice in which MERG-D is being tagged with green fluorescent protein. This is some fast blue labeling into the colon, which travels back to the cell body and allows us to see which of those DRG neurons are projecting to the gut. This is CGRP, so you can see that the MERG-D and CGRP don't overlap at all, and these are two distinct populations. And indeed, you can find that we've got sensory neurons that are expressing MERG-D that are projecting to the bowel. So this was quite an interesting finding, and it suggested maybe that MERG-D was important in the response to 5-oxo-EAT. So we did some studies where we knocked down MERG-D, and indeed we lost that response, suggesting that 5-oxo-EAT released in the bowel of IBS-C patients was actually stimulating nociceptors through MERG-D. And we backed that up by looking directly on colonic nociceptors. And we saw that about, again, roughly a third of them responded to the application of 5-oxo-EAT. So we think we found a new drug target for the treatment of pain in IBS. We think what's causing pain in IBS-D patients isn't the same as IBS-C patients. And actually, if we return to this sort of correlation of nerve firing, with pain severity, as well as having a stratification based on hypersensitivity, we did wonder if part of the reason we were only seeing a response in some patients, in some nerve fibers, was based on the expression of different receptors. So in essence, we have a set of sensory nerves that respond to IBSD stimulus, and we have a set of sensory nerves that are actually primed to respond only to supernatants from IBS-C patients. So the ones responding to IBSD would have 5-6-EAT and act via TRPV4, whereas the ones responding to IBS-C would be active to 5-oxo-EAT and express the MERG-D receptor. So to sort of round off, what we did is we went back, we did a single cell RNA-seq study where we tried to understand precisely which genes are expressed in the sensory nerves innervating the bowel. This was work supported by Neurocensus at the time, part of Pfizer, that spun off specifically to look for new pain medications. So this was driven by James Hockley, my PhD student, and later taken on by Ewan St. John Smith here in the department, who finished the work with James. So James picked sensory neurons projecting to the bowel, and he performed cell RNA-seq analysis of all 20,000 genes expressed within those sensory neurons. And what was really nice about this work is through an unbiased clustering approach, he was able to identify the presence of 7 subpopulations of sensory neurons. So rather than just simply being 2 peptidergic, non-peptidergic, in fact, there were 7. If we look at them in a bit more detail, 5 of them were projecting through the lumbar splanchnic nerve, and 2 of them were only projecting through that pelvic nerve, which I showed you early, it innervates the rectum. So 5 in the colon, 2 down in the rectum, and each could be distinguished by a cluster of discrete gene expression. So James is a clever chap. He put together a website that he and Ewan curate, and you can type in your gene of interest and it will display that gene of interest across those 7 different populations. So if we put MERG-D, the receptor that we think is activated in IBS-C, then you can see its expression in that exclusive population of splanchnic nerves. So this is really quite interesting. It suggests that a lot of pain in IBS-C is actually coming from the colon rather than the rectum. We can type in other channels and other genes that we think are important in driving pain in the gut. So this is ASIC3, which worked from Stu Brierley's group many years ago now, showed was important in colonic mechanotransduction. But when you type it in, you see that actually its expression is only within a certain subpopulation of neurons. If we type in TRPA1, which again, Stuart showed some time ago is very important in colonic mechanotransduction, and we get a much more robust response in the TRPA1 knockout. I showed you the data at the start of my talk. Then you can see actually the reason for that is the much broader expression of TRPA1 throughout colonic sensory neurons. And you can see that there's some overlap between TRPA1 and ASIC3, but actually there's lots of sensory neurons that only really have TRPA1 and not ASIC3. So if you were targeting these receptors to treat pain, you'd probably want to start with TRPA1, not ASIC3. And certainly if you were to go into the pelvic nerve and into the rectum, then you can see that they're expressed on completely different populations. This one we think is important in triggering defecation. This one we think is important in mediating pain. So in terms of rectal pain, one would definitely want to treat or target TRPA1 over ASIC3, yeah? So can we back this up? Well, certainly for a long time, there was 2 treatments for IBS. One for IBSD was a 5-HT3 antagonist called alozatron. And if we look at expression of 5-HT3 receptors, we can see that it's very widely expressed, including those pelvic populations. And there was a treatment for IBS-C, which was tegaserod, which targeted the 5-HT4 receptor. And rather interestingly, this is only expressed in a subpopulation in neurons, the same subpopulation of neurons that express MERG-D, which was the receptor we showed was targeted by 5-oxoate. So it suggests that these populations have a disease specificity about them. And what's really exciting about that moving forward is we can search this database. We can look at the MERG-D population, which we think is important in IBS-C, and we can look to see what else is there that might represent a useful treatment. And so I think I'll finish on the last couple of slides, just explaining what we did. So if we look at that population, we can find a high expression of a potassium channel. This is a small calcium, small conductance calcium activated potassium channel subtype. And we can go, and so we can see that this is highly expressed within that MERG-D population. We can target that with an opener. So for these studies, we turn to the appendix, which we can put in the tissue bath in the same way that we take mouse intestine, and we can distend the human appendix in the same way that we can distend the mouse intestine. So we've got this sort of direct correlation between the two. And if we give an opener of SKCA channels, SK31, you have to give it at quite high concentrations, we can indeed inhibit that activation of mechanically sensitive afferents. And actually, if we pull out individual nerve fibers, then we can see that the ones that are only responding at those noxious distending pressures are actually completely abolished in their activity by this SK31 opener. Yeah. So we think, just to summarize the data I presented today, that we can actually, validate targets based on stratification of patients, but also the nociceptor signaling pathways through which mediators specific to those particular pathways signal. And we think this obviously would greatly improve the translational success for the treatment of visceral pain moving forward. So I think in the interest of time, Dev, I'll park up there, yeah, and leave some time free, yeah.
Thank you, David, for a wonderful talk. And that's it for this term, and what a lineup we had. Join us next time when we welcome Dr. Ben Underwood. Ben is an assistant professor in applied and translational old age psychiatry at the University of Cambridge, an honorary consultant old age psychiatrist, and the R&D director at CPFT. His interests are in translational medicine, in dementia, where he has been an PI for academic and pharma-led clinical trials. Furthermore, he is the clinical director of the Windsor Research Unit, a facility dedicated to joining NHS patients with clinical research. He will be asking, can we have jam today and jam tomorrow, improving outcomes for older people living with mental illness using applied and translational research? Don't miss it. For more info on the talks covered in this seminar series and all things neuro-related in Cambridge, please follow us on Twitter at CamNeuro and follow the links below. See you next time.